join. A lot of people RSVP'd for this one because it's a good topic about a pharmacist's perspective on benzodiazepines. So just tell us where you're from, and I'll look down in the comments and see who we got.
Well, I'm going to go first. I'm from New Hartford, New York.
Okay.
I'm broadcasting from my dining room today.
Perfect. And I'm actually in Camarillo, California, which is a little north of LA. We got somebody from Lufkin, Texas. I actually know where that is, right outside of Livingston. That's where my home address is. So welcome to you in the audience. All right, we got 6 people tuning in. Okay, so let's give it like 30 more seconds, and then I'm just going to jump right into it because I am a pharmacy nerd at heart. I'm excited to learn about this today.
Okay.
All right, let's do it. Okay, I think we got enough. All right, let's get started. So hello, everybody. My name is Angie Peacock. I am a psychiatric drug withdrawal consultant and a healing coach. I help people that are coming off meds of all kinds. I enjoy bringing important conversations like this one today. I love talking to important people that are like changing the paradigm of care and helping patients that need it the most. So today we are speaking with Dr. Jolene Bressi from the Alliance for Benzodiazepine Best Practices. Welcome, Jolene.
Thank you for having me. I have to say thank you so much for doing this conversation. I know we had a little delays on our Monday conversation, so I hope people can at least view and attend today.
Yes,
yes, fingers crossed. So
we're good. Sorry, we had some technical difficulties, but hey, things are meant to be. So maybe today certain people could tune in. I'm not going to be upset about it. So this interview is part of a series it's a 5-part series with the Alliance for Benzodiazepine Best Practices. We talked to Bernie Silvernail last week. He's the founder of the Alliance. Let's just refer to it as the Alliance. It's such a long mouthful for me. And today's the pharmacist perspective. So I'm going to read her bio and then we'll jump right to questions. If you have a question that pops up while you're comments, and I have someone, my assistant Jill, she's in the, she will send me all the good ones and we'll ask her right on the spot. So Dr. Jolene Bressi PharmD PMP completed her degree at St. Joseph's University in 2003. She has a diverse practice background with over 20 years of experience in community, hospital, industry, McNeil Consumer Healthcare, CVS, Rite Aid, Benecard PBF, and Appriss Health. She has worked on controlled substance management programs over the previous decade to ensure best practice utilization for large patient groups. And now, what is your title at the Alliance?
I'm a board member. So actually everyone that you're going to be doing interviews with is on our board. We have a lot of medical personnel in-house. I think that's what is, you know, we are very medical and science focused at the Alliance. And I think that's kind of what sets us apart because we have so many in-house professionals. I know some of the other groups like BIC also have like Dr. Christy Huff, she's great. We really take that science bend and then we try to advance the study and the research within this space. Currently, we're even working on research topics with international researchers and pharmacists and doctors. So I really like that about the Alliance.
I do. I'm a science nerd. If all my cognitive abilities were back, I'd probably do research myself because I just love it. It's an awesome topic. All right, so let's start off with, can you just share about what inspired you to become a pharmacist and how did you become involved with the Alliance in the first place?
So my grandfather got ill. I was very close with my grandparents growing up, and my grandfather got ill with cancer when I was around 10 to 12. And that was a defining point in my life. I knew I wanted to go into medicine. However, I did not like blood, any kind of blood. So I knew that my choices were going to be limited. And then by the time I got to high school, I knew I really liked biology and chemistry and physics. Sciences were my thing. So my mom's like, I think if you want to do healthcare, pharmacy would probably be your best bet, given what you like and you don't like. And that's why I chose pharmacy school. So I went into an entry-level doctorate program right out of high school, 17 off to college. So it was, but I've enjoyed it, and I've done a lot of different things. I've practiced in so many practice settings because I think that broad base and getting that view from multiple perspectives is so important. So although I started out in retail pharmacy, which most people are familiar with their retail pharmacists, they might even know them by name. And that's what I liked about retail pharmacy, because you have that patient level interaction, you know your customers, they know you. Same thing with hospital, you got a lot of patient interaction, you know, you rounded with the physicians, you were on the patient floors. And then I became a mother and I needed a job that worked from home. So I went into managed care practice, and I had a job that I worked from home for the past decade. So yeah, that's a little bit about me.
You got a little bit of everything. That's awesome. So can
Yeah.
you talk about, just so the people in the audience, I am a huge fan of pharmacists because I think they know more about drugs than the average doctor knows. So can you kind of share about what kind of training do pharmacists get? What do you guys learn about drugs? Like, just give me like the overview of like, this is what pharmacists are trained to do.
So I love this question because I'm actually married to a physician. So I got to see what I went through in school, and I also got to see what his training looked like. So my training, like I said, entry level right out of high school, first 2 years, you do your undergrad. After that, you are pharmacy for 4 years. You are studying pharmacology, pharmacokinetics, pharmacodynamics, pharmacy calculations, compounding pharmacy. You learn every aspect of pharmacy. And then you do 1 year that is purely rotations. So in that year, you're seeing people in community healthcare practice, in an industrial practice. You do internships in summers before that last 1 year intensive experiential programming. So you get 4 years of intense training. What I know to be true for roughly, like 15, 20 years ago with med school is that you got a 6-month course of pharmacology. I can tell you that it was much more intense for a pharmacist versus a physician, MD, DO. Nursing programs may get around a year. So even though these are the prescribers of the medication, pharmacists actually carry with them an equal responsibility to make sure that the right patient is getting the right medication at the right dose.
Yep. I love that saying. I love that. And even then, I don't want to be controversial so early, but even then, even if you get the right medication to the right patient at the right dose for the right thing, sometimes things can still injure you, right?
They can. And that's why the pharmacist role to me is so important, because it's that informational piece of letting patients understand the risk and the benefit, and that really nothing comes without a risk or a benefit. Anything that you put into your body is going to have that. So I like to just have that little interface with patients, and that's honestly what I like the best about community practice.
I like that. I don't think we take advantage of that. I know me myself, every time I would go to a retail pharmacy, they'd say, do you have any questions for the pharmacist? And I would say, no, thank you. And I would just take my meds and go. Right. But I think that's the moment where you stop and you ask those questions. I don't care if it's a new drug you're prescribed, an old drug that you've been taking. I think that's so important that you take them up on that. So can you talk about, like, how do patients create a better relationship with their pharmacist? How do they use their skills for our benefit?
Well, again, it's asking questions, because the pharmacist can't know what you're not revealing to them. So it's really about asking those questions. Also, I understand, as a working professional, as a mom, how busy you may be when you go to pick up your prescriptions, but always realize that you can pick up the phone after the fact. You can call the pharmacy. You can say, can I speak to the pharmacist? I have a question about my medication. I'm supposed to start this medication later on today, no matter what medication you're taking. If it's any mental health medication, even if it's an antibiotic, you should be thinking about that. You will have time to, get home and get settled down. It's never too late to call.
Yeah, that's awesome. So what is the role of a pharmacist, like within the healthcare system? I don't know. Can you explain that a little bit?
So again, the pharmacist has this corresponding responsibility with any healthcare provider to educate both them and the patient about getting the medication, the right dose, just conveying the risks and the benefits. Maybe the doctor isn't aware. Maybe they've been practicing for the past, 20, 30 years like myself. And this isn't, a field, maybe they don't do mental health care every day. And you're coming to them with a problem that's a little outside their wheelhouse. So that's where the pharmacist can intervene. And we provide a lot of educational pieces, especially at the Alliance, because actually Lori Moore and I are working on a CME. We've already delivered one about the pharmacist in a nonprofit setting, and we delivered to an audience of over 700, just outlining what the pharmacists at the Alliance do. And we're set to deliver another one, and I will share it with you, and you can share pieces to your audience. It's about benzodiazepines, and the title is The New Kind of Pandemic. Yeah. So I think it has a lot of relevance, especially with what happened most recently to everyone in this country with COVID. It put mental health at the forefront. Besides just physical health and, disease spread, it also had all of these like snowball effect of problems that it caused because we were home, we were away from people that we loved, we knew we couldn't interact. It was very traumatic for everyone.
It was really sad to me because I got clients that booked sessions because they had really bad anxiety during the pandemic. They watched all the newscasts. They were afraid. Even I, watching NBC Nightly News, they would say, tonight, just that would give me anxiety, like, oh my God. So they went on because they had legitimate anxiety, but it was contextual. It wasn't because they had, they needed a brain chemical. They were missing Xanax or something. And now they're, the pandemic has slowed down a little bit. It's more quiet and they want to get off and they're having a really hard time getting off. It's kind of upsetting,
It is upsetting. And I actually experienced this myself, like having a child at home. I wasn't prepared to be a full-time teacher in just adding that to the mix of everything else. It was really difficult as a working mom. So, and my child actually has some learning challenges. So that was also difficult because I don't learn the same way that he does. So understanding how I had to provide the learning and providing it in the right way caused me a lot of anxiety. And I too was watching the news. I actually had to stop myself from watching the news.
Yeah.
It was deteriorating my own mental health because it felt very much like, are they giving a body count every night? Like, this is not, as a healthcare professional, what I think we need to hear. Yeah. So there's that filter that, sensationalizes things in the media, and we have to block that sometimes.
So true. So let's move into deprescribing. First of all, define it because maybe people don't know that word, but then talk about what kind of training do pharmacists get deprescribing? And maybe you could even mention doctors. What do they get deprescribing?
So I can tell you that 20 years ago, deprescribing wasn't a topic we even learned about. This is something that a lot of providers who have been in practice for some period of time have to go and educate themselves on. And that's what I chose to do in this space. Deprescribing is when you, your doctor, your pharmacist are going to evaluate if the current medication regimens are those that are right for you, and then look to discontinue or eliminate medications that may not be appropriate for you at this point in time. Maybe they were appropriate a few years ago with what you were going through, but maybe they're just no longer needed. And this reevaluation process should be done on a regular basis. Again, pharmacy education has come a long way. So this is actually a topic that students now are learning about, doctors now are learning about, nurse practitioners are learning about. So it's kind of exciting, but the clinical decision-making framework that is there for certain kinds of prescribing is not necessarily there for deprescribing. And it's a more nuanced experience as well, because everyone goes through their own experience when they're coming off of a medication. It isn't a one size fits all, and really understanding what works best for the patient, and then taking those symptoms and really working with them how to alleviate or eliminate them. Angie, I can't hear you. I'm sorry.
I had mute on, sorry. I was sorry. Okay. Deprescribing as a general term is usually referred to in the geriatric population, so people over 65.
Yes.
I don't think it's quite in there yet with people on mental health medications. Like deprescribing is a valuable intervention for that if patients are not doing well. Do you know anything about that? Like,
it's funny that you said that, because Lori and I are doing this CME that I told you about. It's sponsored through PharmCon. We'll be doing it Monday, May 1st at 10:30. It will be delivered towards pharmacists, pharmacy technicians, and nurses. But currently, their body of knowledge that they teach about in the deprescribing wheelhouse is in the population 65 and older. So this is going to be a new sort of education that we're bringing to light as far as mental health medications. And since I've been working in that space for the past decade, that's kind of where my heart lies.
of that, yeah. I'm getting proud of the alliance. Like, you guys are leading the charge here.
You're breaking up a little bit. So
oh no, our internet. This is
okay,
terrible. I might
okay.
run outside. You might just see me run outside and
No, I
and
can
sit
hear
next
you
to
now. I
Starbucks.
can hear you now.
Okay. Did you hear what I said? I said I think the term deprescribing is going to gain more and more traction in the coming years. And I think I'm really proud of the alliance because I feel like they're leading that charge. Yeah.
I agree. And there are already pathways that, pharmacists lead the prescribing or deprescribing of medications. They're usually in a collaborative care setting, and you'll have an agreement with a doctor or a nurse that you're able to prescribe or deprescribe based on patient-specific needs. And that's what I really like about it as well. Pharmacy really can help here because we do get all of those advanced years past what is, and like I said in the beginning, I don't have to worry about necessarily learning how to draw blood. There's a lot of things that I, as a pharmacist, don't know how to do that a doctor or a nurse does better. But this medication piece, pharmacists have that key missing piece of the puzzle that maybe, they're not, a doctor or nurse doesn't have as much information about. So I
like
do
that. That makes me think though, should it be pharmacists leading the charge about how to deprescribe patients?
Oh, I think there are. And I know that, like, Lori, particularly, she's another board member who is a pharmacist. Her and I, not only are we educating about this, but she does this in an ambulatory care setting. So she has, she works in collaboration with physicians. And she'll actually be working at Yale New Haven soon. So that's another thing that, like, she's going to these higher, very prestigious university setting that she's able to lead the charge there. And that really is important that, you lead from the front, not really just staying there in the background. So pharmacy, it does want to come to the forefront. That's important.
Yeah, I think it's more important just because I've never really thought of that. I always think like doctors are closer to the patients. They should be the one to say, go slow. But and we're going to get, that's our next question. But since pharmacists really know how drugs work and what they do to the body and how they eliminate and what's the process of detox, all of that in the weeds kind of stuff, I think they have more of the knowledge base to really know how to do that slowly and patient-led, patient-directed. So let's talk about that. You mentioned the terms pharmacokinetics and pharmacodynamics earlier. I know what that means, but can you explain that to our audience, what that means? And then about
Oh, you're skipping. I heard pharmacokinetics and sorry. Okay, pharmacokinetics and pharmacodynamics are how drugs work in your body. So how they're administered, distributed, metabolized, and then eliminated. So those are the like four main things that you're dealing with when you're dealing with pharmacokinetics or pharmacodynamics. So we call it ADME, ADME, administration, distribution, metabolism, and excretion. And this is how your body functions throughout the entire process of you taking a medication. So when you think about when you take an oral medication, which most of our mental health medications are oral medications, you take a tablet, you take a pill, and it has to be taken, absorbed into your body, distributed throughout your body. It's not just one part of the body that's getting the medication, it's your entire body that's getting the medication. So you're not having this targeted like neurospecific reaction when you're taking a mental health medication. You're going to have, even when you're coming off of it, you're going to have a lot of, say, GI side effects, because think about it. Those are the cells that are first absorbing it, distributing it, and then eliminating it. So there's a lot more going on than meets the eye. And that's what we learn about in pharmacokinetics and pharmacodynamics.
I love that. Actually, I was on a panel for Medicating Normal about a month ago, and somebody in the audience asked, how do medications get absorbed in the gut and how do they affect the gut? And the doctor said, well, he was on the panel with me. He's like, well, I can't tell you everything, but I just want you to imagine this. He's like, when a drug enters your body, it has to permeate the gut wall, go into a cell, go into your bloodstream, go and break through the blood-brain barrier. And that's how drugs work. We think if I just take a pill, it'll just go to the site of my anxiety and it'll just take it away. But that's not, there's so much more to it. The body is a beautifully orchestrated, I don't know how to explain it. Like this, everything is connected, everything is working, and it's distributing that drug throughout the body. All kinds of stuff is happening. So I don't think we as patients really take, I should say the whole system is not humble enough to realize like this is impacting the whole body, the whole person, your personality, your thinking, your hormones, everything when you take a benzodiazepine, really.
It does. And that's something that, I think pharmacist-led interventions there could really help inform the patient. And I know that there's a lot of, debate, and there's even been legislation proposed, like in Massachusetts, with informed consent. And these are things that, like, as a pharmacist, I take for granted that I have to already educate that patient. It's not just about that informed consent. If you get a new prescription, I'm going to be at that counter and I'm going to say, I need to talk to you about this before you leave. So, and I think that that's how pharmacists are more and more acting, as far as like giving the patient a choice. If they say, I don't have time to talk, I'll say, I'll call you later. I have your phone number. It's okay. So, and it's just having that friendly face sometimes as well. No matter what kind of day I'm having, if I'm showing up for a patient, I put a smile on. So
yeah, we need that.
Yeah.
So now that we're talking about how drugs act on the body, let's get really specific to benzos. What are the mechanisms of action? I think you need to define that term. I know what that means, but what are the mechanisms of action of benzodiazepines, and why are some of us so Like, I don't know what to use the term. Should we say we're injured by them, or we're physiologically dependent on them and it's hard to get off? Can you talk about benzodiazepines in specific?
Yes. So benzodiazepines, and this actually is part of what the presentation that I'm going to send you. I find it so interesting that when they were first discovered, they didn't even know how they worked in the body. So the mechanism of action is how they work in your body and what receptors they're binding to in your body. It took 15 years for them to discover that they were acting on a GABA receptor. Now, GABA receptors are very present in your nervous system. They're also present in other parts of your body, but highly prevalent within your nervous system. So by activating these GABA receptors, a benzodiazepine binds to this receptor and allows chloride to flow through. So that's how you feel this relaxation. Once you take these, say 2 to 4 weeks, your body becomes tolerant to the fact that you are taking these and that this deactivation of your nerve cells is ever present. So when you take the medication away, you have this overstimulation of your nervous system. And I like how you said, there are people that may be able to come off of benzodiazepines very easily, and then there are those that can't. And, understanding the differences between individuals, even at a cellular level, we know we're all a little bit genetically diverse. There's so many subunits. There's 15 subunits to the GABA A receptor. I mean, that's huge amount of diversity within the population. So there's no good way to predict who's going to have these severe adverse reactions and who is not. There's just no good way to do it.
Well, so that brings up informed consent. Like when you take a benzo, nobody, you know what I mean? It's kind of like, you don't know, you could be fine and you could not be fine. Like, you just don't know. You just don't know. And when you come off, I think that's the hardest part. Like when I have sessions with people, the hope of tapering slowly is that you will minimize the amount of severe symptoms or protracted withdrawal. However, I've seen it over the years in our community. You can taper. I don't want to scare anybody. I know this is probably going to scare you. I'm really sorry, but this is informed consent. Like sometimes you can taper perfectly fine, perfectly slow, and you're watching everything and you're not, messing anything. And patients hit a wall of tolerance anyway, and then they start getting symptoms as they taper. So I think that's so scary to me that we just don't know how these act on us individually and what's the perfect way to get off. Or I feel like we do a disservice to patients by not warning them ahead of time. It's terrible.
Exactly. And a lot of people do have, it's hopefully something that'll work in a reverse algorithmic sort of taper, but that's not necessarily what's done in practice. Sometimes they take you down in a linear taper. There's a lot of tapering methods. What I advocate for is that reverse algorithm taper. And usually there's a tail end there. You're going to get a longer and slower amount of a taper at the end. Mm-hmm. I like to take things really low and slow, but not everybody is going to have that approach. So, and linear does work for some people, dose skipping. There's so many different ways to deprescribe, and having this available. I know I talked to you earlier and I bet Bernie touched on it, but the FDA is actually working on this dilemma right now. They're coming up with deprescribing guidelines that will be grade level methodology. So that's important. That's a huge study, but it's not due out until 2025, 2026.
Oh God, come on, hurry up. But here's my thing. I always push back against that. I know it's going to sound controversial, but I don't know if it's, okay, so for instance, you said some are linearly tapered, some are, so for instance, for patients listening, sometimes they can say, take 10% off your original dose. The other way is a hyperbolic taper, what Jolene is talking about, where it's very slow and low. That one's called hyperbolic taper, but it's 10% of your current dose, 5 to 10% of your current dose. So it's a difference between original dose and current dose, how slow and how choppy that taper is. However, I get to hear all the stories of all the nightmares of tapers. And mostly in practice, neither one of those is practice. Usually it's a cold turkey withdrawal, or it's
Mhm.
within 2 to 4 weeks that the patient is cut off very quickly. We can get into the weeds later, but it's really heartbreaking for me to hear, because again, back to the informed consent piece, if we don't know how these will act on your body, we don't know how you're going to act when we deprescribe you. So why isn't that brought into the conversation? Like, hi, there's multiple ways to taper, but this is where I think the Alliance is filling the gap, because there is not CME training for tapering benzos at a patient-led rate currently. Am I correct?
Well, Lori and I are doing it May 1st, pharmconfreece.com for pharmacists, nurses, and pharmacy technicians to learn about different deprescribing methods for benzodiazepines. So we do want to lead the way there. We know that there's a lot of variability, and this is something that we actually talk about. You know, maybe somebody is able to go cold turkey on something. I know, you know, my mother-in-law, she smoked for over 30 years and she was able to cold turkey stop. That's the exception. That's not the rule. Understanding that if you're on a benzo for a long period of time, say for many years, and you just being able to stop, that's an unlikely scenario. That's not the likely scenario. And really just having that conversation with patients. The other thing with the deprescribing is that HEDIS metrics. So that's a government set organization that really looks at quality across health plans. So your payers, is this a good quality payer? Are they giving you the services and the pharmaceutical care that you need? HEDIS metrics in 2022 actually gold for a 50% reduction in benzodiazepine use for those 65 and older. So what you're talking about with these forced tapers is actually part of what the payers are goaling for. So when you look at the 3 different tiers, it went 10%, 25%, your highest level goaling was this 50%, and really understanding how your plans work as well. It's not just how drugs work in your body, but understanding how these medications get paid for and different quality control metrics that health plans are actually held to.
Well, gosh, I will just tell you, yesterday I had 2 brand new clients over age 60.
Mhm.
And for that population, I always have such a hard time, because I said to both of them, informed consent for deprescribing when you're over a certain age. And I'm referring to the Beers list. Maybe you can describe what the Beers list is really quick, and then I'll finish what my thought.
The Beers list is a list of medications that those that are 65 and older should use caution or potentially avoid use.
So for these 2 that were over age 60, one was 62, one was 64. I said, you know, if you're going to read a lot of the support groups, if you're going to read about the Ashton manual about how to taper off benzos, I need to give you informed consent for that. So if you are up in age, to me, it's just a matter of time before either the payer stops paying because of your age, a pharmacist is going to flag and say, hey, you're over the age, this is on the Beers list, or a doctor is going to, you know, change, and then you can't get a prescriber to prescribe you benzos, or you go in for surgery and they cold turkey you because they think that you shouldn't be on it. It's not an appropriate medication for your age. So it is somewhat in your best interest to find a prescriber that will help you taper now while you feel healthy, while you feel good, because I can just tell you, I have people right now that I'm supporting that are in their 70s that have been deprescribed very quickly, very inappropriately. And these people are living off of disability all on their own. They have no support, no care, and it is heartbreaking. So like the groups are well-meaning, saying, you know, get off, you know, taper like this, taper like that, but you have to take age into the equation, and the person, I always say to them, do you want to spend the next potentially 1 to 3 years, you know, deprescribing and then healing from, you know, 30 years of benzo use? It might not be even up to you. So to me, it's such a tricky area. Can you talk about that? Because I see this all the time.
It is a tricky area. And it, you know, nothing exists on its own. It's, there's so many different levels. I know we were the Alliance members, so all the members that you'll be doing in our panel discussion with you, we're actually on a call with the Pennsylvania Department of Health, the director for the PDMP, which is the Prescription Drug Monitoring Program. And we were talking about benzodiazepines and what they're seeing in the community and what the problems are that they're hearing from community members, and especially, advocacy groups. And what the director said to us is, we're experiencing providers that are just, like you said, de-prescribing. Maybe it's an older provider, they're retiring from their practice. Maybe it's somebody younger and they're learning about a lot of these harms that are now becoming more public as far as benzodiazepines. Or maybe it's even something that's a payer-initiated goal, like I had stated with HEDIS metrics. So it could be any of these factors. And then people are going, they're getting de-prescribed, they're having these severe symptoms. And really what the problem that I see as a very large problem is, a lot of times these people then go to an illicit market, and you're getting who knows what in an illicit market.
Right. It's tricky. So yeah, I don't know. My hope is, this is always my hope, that patients are allowed to taper if they want to, when they want to, as slow as they want to, and that providers will support that to all ends. Supporters across the, providers across the board, because people move, the doctors change jobs, so I would wish that all providers allowed that to happen. So and especially when you get up in age, I think it's cruel and inhumane to take someone off in their 70s if they don't want that.
If they don't want that. And I actually advocate for the same thing. So it's patient-led. So what does the patient, maybe you're 70 and you're noticing things like cognitive impairment and you want to get off of it. So these are things that we know benzodiazepines cause. So when you think about it that way, there can be patients that really do want to get off it. They're thinking, oh my, something's not right. This drug is affecting me way more than it did 20 years ago. What is going on? So like in those situations, it really needs to be the patient come into their doctor, come into their pharmacist. And, a lot of people don't have that face-to-face time with a provider. Usually, I don't know about your providers, but my own experience with doctors or nurse practitioners or PAs is that I might get 10 or 15 minutes. That's not enough time to really talk about much. Like, you're going to probably hit my blood pressure first, oh, your blood pressure is too high, you're drinking too much coffee. So are these the top priorities that you're talking about with your provider? Well, let me come back to that. And because if you don't have the time to talk to your provider, your prescriber about it, you can go and talk to your pharmacist about it. And they can call up your provider and say, Jolene's having some issues with, her medication. I want to see what we could do to work on that. So you don't even have to have that conversation. You can have that conversation with your pharmacist as well. Don't forget about your pharmacist in the mix.
I like that. Okay, so we have a couple questions coming from the audience, but I'm going to combine it with my next question that I had. So some people are asking about how do benzos affect like your thyroid or your cholesterol? How does gabapentinoids, so gabapentin or Lyrica, how does that affect the central nervous system and the body? So my question is more like, how do these drugs work? And I want you to go into the receptors and the whole theory behind what is happening. Take me more into the body at the receptor level.
Okay. So you have a GABA receptor. It sits on the end of a nerve cell. When you think about nerve cells, they're everywhere in your body. They're not just up here. So think of it as a whole person instead of a section of a person. The GABA receptor sits at the end of the nerve cell. Benzodiazepines come in and they bind to the end of that. This opens this channel within this receptor. Chloride is allowed to flow through. So chloride is a negatively charged molecule. So it flows through. It basically opens up this nerve cell, and it allows it to be desensitized in some way. So it's turning things off. And when you think of it like a switch, it's almost like an off switch. So you're going to, your nervous system's notching down a little bit. Now, as you take these for a prolonged period of time. Now, when I say prolonged, that could be as little as 2 to 4 weeks. I'm talking like if when you take these for a prolonged period of time, 2 or 4 weeks is when you can notice tolerance to these medications. This nerve cell, if you take that benzodiazepine away, so this cell isn't switched off, you can have this hyperbolic reaction, but you're going to go up like this instead of coming down like that on a taper. So you're going to have this hyperbolic reaction because that chloride's no longer allowed to flow through that channel, and those are turned on, and you're sensitive to that. The body is sensitive to that.
So that would look like agitation, irritability, extra anxiety. I can't sleep. I have too much energy. I have muscle pain. I have muscle weakness. I have, I don't know.
Akathisia is a great one. You could even have a lot of GI side effects. There's a lot of people that come to the Alliance having, intense GI side effects. So, I don't want to be too descriptive here and like turn anyone off, but think about it. It's not just your brain that is receiving the benzodiazepines. Your entire body is receiving it. And that's why you're going to have a lot of these muscle side effects as well. Your muscles are actually absorbing benzodiazepines. So when they're taken away, they have this hyperbolic reaction that they're like, what? Yeah.
So I have to ask this because I already know this is the question in the audience. When they hear that, everybody gets scared. Oh my God, is that permanent? Does that mean I'm going to heal? So like what happens in the nervous system if you come off and you have that hyperbolic reaction, that hyperexcitability? The healing process, at least in my experience, has been a slow, gradual, it kind of goes back to normal. So can you talk about like the healing? Give us a little bit of healing knowledge.
Everyone has their own time frame. And you know this from dealing with patients for a long time. Everyone has their own time frame. So, what does it look like? It can look like 6 months. It can look like a few years. There is a healing process, and eventually it will notch back down, but it takes time. And that's where, honestly, I think that therapy is important to help you, and collaboration with your providers, be it your pharmacist, your nurse practitioner, your PA, your doctor, really understanding that portion, that this is going to take time, and coach you through that, because it's an awful experience. People they're thinking, oh my, like, is this actually happening to me? And it feels like, it feels overwhelming. Benzodiazepines are also linked, especially long-term use, with suicidality. So these people are having very extreme side effects. And this is even people that have gone off of the medication. It's really, what the Alliance aims to do is reduce the overall number of prescriptions, because we already know that they cause a lot of harms. So if we reduce exposure, then there will be overall less people harmed.
Right. So yeah, I think that's the disservice. Is like, I know I went on them for anxiety and post-traumatic stress, but then when I came off, it was like 100 times worse, 1,000 times worse. And I wish that I would have learned, things like guided meditation or somatic experiencing, or just had some love before I ever took them, or at least informed consent to say, if you take these, you could possibly go through withdrawal, and it could last months and years, and it could be very severe and worse than your original condition in which you were put on them for. That's the part.
I don't want to be too controversial in saying this, but I know, like, I'm on a lot of the benzodiazepine support groups, and I listen to the conversations out there because I care and I want to know what people are saying. And someone actually posted the other day, Like, this is worse than withdrawing from an opioid. You know, you don't understand. With an opioid, you're going to have a less protracted withdrawal period. So again, working in the controlled drug space, I do know that as a fact. You know, you're going to have a more linear way down and off of the medication, where you may have a protracted experience when you're coming off of benzodiazepines.
Absolutely. Yeah. So let's talk about tapering. Because basically that's what's happening. There's tons of patients. This is also controversial, and we can't help it. You can't help it. Okay. Because of the lack of training within the medical community, because of the lack of CE and CME, because of the lack of training I mean, I'm hoping it's coming. Okay. But patients can't wait until everybody gets trained up. So many patients, the whole community has sprung up of people tapering. And usually they do it on their own, at home, quietly. They might try to get their doctor's help. Sometimes they're open to it, sometimes they're not. I find DOs and naturopaths to be more open to helping people taper, or functional medicine doctors, people like that. So I want to talk about the nitty-gritty about tapering, just about like different brands, the margin for error between tablets, capsules, and how much they weigh. Like 1 milligram doesn't really necessarily equal 1 milligram. Liquid compounding. Can you talk about this from a pharmacist perspective, like methods of taper, methods, different formulations of a medication, that kind of stuff?
Okay. First of all, even when you're talking about one medication, let's take Valium as the exemplar here. When I look at the brand name compound and I look at the generic compound, they are not identical in the tablets, because although they may contain, within a margin of error, say 5 milligrams of medication. So if I'm comparing a 5 milligram tablet to a 5 milligram tablet, I also have to understand that there's a margin of error between the two products, that it may or may not be 5 milligrams. And they also use different excipients in a generic product versus what a brand product. They do a lot of pharmacokinetic studies on the medication, that they have to be similar, but not exactly the same. So they have to behave in a similar fashion in your body. So that's one way that medications are different. And then when you're switching between, say, one generic manufacturer to another generic manufacturer, you still have that variation. So the generic manufacturers, they use the brand product as their exemplar. That's what they use in clinical trials to get approved. And again, every drug manufacturer may have a different margin of error that they're working on. So that goes back to what you were saying about like pill splitting and cutting. You may experience, if you switch to a different manufacturer, that the product is not working the same way in your body. That's because of, it may not be the same milligram dose. It's within the FDA approved margin of error, but maybe there's something else in there that, an excipient, that's what they call all these fillers that they're putting in the medication. So, the fillers may not agree with you. It could be a reaction to a whole host of things, but there's no way that you can necessarily differentiate. And that is where the patient-guided, methodology needs to come into play. That, like, if you're experiencing, say you had to switch manufacturers, your pharmacy's no longer getting in the brand that they used to, and you're experiencing different side effects, you need to go talk to your provider. You need to talk to your pharmacy. And this is actually where the pharmacist can play a role, because many times, and I know I've experienced this myself, in younger years with birth control pills, a lot of people have that as a perspective, and noticing that when I change from one manufacturer to another manufacturer, these are not behaving the same in my body. So go talk to your pharmacist and ask them, say, what was that manufacturer I was getting maybe, last month versus this month? And can you get in that same manufacturer? 9 times out of 10, they can do that for you.
And I don't know if you can answer this question, but a lot of patients want to switch. Like they might be at the beginning of the taper. They're not having a whole lot of symptoms. but they want to go from a tablet to liquid, because when you cut a tablet, you don't know exactly where that active ingredient is dispersed, if it's even or not. You could be cutting off some filler. So it's more precise, obviously, to go from a liquid that's more evenly distributed. It's in a solution or a suspension. But when they do that, you know, it's always like, do I do that now before I'm having too many bad symptoms, or do I do that later? And I always say 3 things can happen. 1, you'll feel better. 1, you might feel a little worse, or 1, nothing happens. And so you have to kind of weigh out that decision. Like, if it gets a little worse, is that okay? Because like, maybe I want to switch because long-term that will help me get off smoother and more accurately. So what do you think about that?
Well, I'm a big proponent of compounding pharmacy. So I do like the liquid taper. I think that for the average person doing this at home and doing it under the supervision of their pharmacist and their provider, their doctor, that it's just going to be much easier. So I do actually advocate for them to do a liquid taper. There's a lot of tediousness that will go on with the pill cutting method. And not everyone has the patience or the dexterity for it. So, you know, especially if you're dealing with a geriatric population, I don't know about you, but I know, like, my grandfather's 89. He couldn't sit there and, you know, cut a pill up. So I think that you really have to hone what you're suggesting down to the specific patient and really listen to what they have to say. Now, say they like, you know, doing something in the kitchen, and that's not their, you know, they're okay with splitting the pills, and that's. And the other part with the liquid taper is that these are compounded medications. Not every health plan pays for a compounded prescription.
Right.
So there's a lot of factors, just like everything we talked about today, that really go into this decision-making process.
Yeah, it's tough. And because we don't have guidelines or even a rough, you know, a rough thing, the patients have been left to kind of figure that out for themselves through the wisdom of our community, because people have been tapering benzos for probably 40 years, and we kind of figured it out. And then thank God for Mark Horowitz, he kind of proved through research on a PET scan that this is how drugs, you know, leave the body, or how the receptors heal very, very slowly and hyperbolically in reverse, not cold turkeying, you know?
Yeah.
All right. So I am done with my questions because I had a lot, but let me shift to the people in the audience right now. If you're watching on YouTube later, this is not live, this is pre-recorded, but so there's a couple. So people do want to know, like, can this affect your thyroid or your cholesterol? Can it affect your progesterone, your hormones when you're coming off, when you're tapering? Do you know anything about that? I don't know if you can answer that.
Well, I know colloquially what we actually hear from people and what the Alliance has said in regards to bind. So bind is a condition where you're having a problem coming off of this. It's benzodiazepine-induced neurological dysfunction. So these are the conglomeration of symptomologies that we hear about and that are actually reported on in the literature. But do we have something as definitive as, you know, a patient-supported metrics like, oh, I'm going off of my benzodiazepine, but that's definitely a definitive cause of my thyroid problem or my cholesterol problem? The causality is not linked in the science at this point. That doesn't mean it doesn't exist. That just means that the literature isn't out there to support that yet. So there can be this conglomeration of symptomology that comes about. But again, the causality is something that still needs to be studied.
Thank you so much for answering that. This is my last question, and somebody kind of touched on this in the audience, but when we were talking earlier, and Bernie actually mentioned this last week. So the process of healing, right? If you're on the other side, you come off the drug, patients tend to be very hypersensitive to supplements, to alcohol, to other substances, to medications. I know I have tons of clients that are like terrified of ever taking an antibiotic again because they can experience like a kick up of symptoms. We call it a setback. So can you talk about, what do we know about the hypersensitivity state of the central nervous system after you come off the benzo, after you come off and you're healing for a time. What do we know about that?
Again, this is an area that we need to study more, but as we talked about it already, and what the PET scans do support is that you have this hyperbolic reaction when the benzodiazepines are taken away. You are more sensitive to whatever it is you put in your body, and you have to show a lot of care and grace to your own self in that process, because it is going to be a process that requires a lot of grace from you and from the others around you. As far as what that looks like in the body, honestly, Alexis would be better to answer.
Ask her that one.
She is,
Okay.
she is the medical doctor. I can tell you from the research that I have done, the research that I've been part of, it really does. I almost think of it as, you know, your central nervous system is like a circuit board. When you think of it like an electrical system, we all have electrical systems within our body. You know, when we take the benzodiazepine, it gets switched down. So maybe it's like a less voltage in your system. This is how I always think of it. When you take away that benzodiazepine, now I'm like, I have all this voltage. My lights are really, really bright in my, house right now. Maybe, people feel like it's explosion. It feels that way. So it's going to take a long time to get that electrical system back into the right order.
Wow. I like the way you describe that. That really helps me. And I can feel that. I think Bernie called it net neural load. I don't know how that relates, but it definitely feels like there's a straw, but the information coming in is way too much and way too fast and way too bright and everything. You can feel everything. And I always used to think to myself, Angie, just because you can feel it doesn't mean it's dangerous or doesn't mean it's like hurting you. It's just, I'm feeling stuff way too much in my body. I'm hyper aware. You can't help but be hyper aware of it because it's just so excruciatingly painful.
Right.
And I think this is the worst experience anyone has to go through. I know for me, it has been, I'm mostly healed now, but it's something I don't wish on my worst enemy. This is a horrible process,
Yeah, it is. And it's a process, and understanding that it's going to take a while, and the long-term harms could be around, we don't know, maybe the entirety of your life. You don't know if they're going to be permanent harms when you start taking it. There's no way to really predict that. So really just telling patients, hey, this is a potential side effect. This is what can happen.
And I have to just step in because you said the word permanent, and that scares so many of my clients. So I will just say, like, what I've witnessed is most of the stuff will die down. And then there's like a little bit of a lingering hypersensitivity or lingering nerve pain in my feet or in my pelvis, or, it's usually not like life limiting stuff that's left over that I've noticed over the long term. So I just wanted to mention that. All right. So
thank you for clarifying.
Yeah, no problem. I just don't want to get extra,
I don't want to scare anyone.
She said permanent, Anyway, okay, so let's close down a little bit, but I always like to end on something hopeful, something positive, something to look forward to. I'm excited about what the Alliance is doing. I think you guys are leading the charge. If I can ever be of assistance to you in any other way besides this interview series, please let me know, because I think this is where we need more focus to help change things, to prevent further harm, because there's just so many of us. I know I see 140 people a month. I'm overwhelmed by the amount of people that are harmed. I want to stop it. So tell us something hopeful, something positive, something to look forward to.
The biggest hope out of this is that there is hope. You can heal. I don't want to scare it. I probably shouldn't have said the word permanent there, but I want them to know that there is light at the end of the tunnel, and that biggest light, at least within the Alliance that I see right now, is the FDA deprescribing guidelines that are currently being worked on. And the Alliance actually does advocate. We advocate for groups like AHRQ to come up with grade level guidance. FDA, same thing. As far as prescribing, we aim to educate our providers in the community, be they pharmacists, nurse practitioners, physician assistants, MD, DO, So there are a whole host of people that we are working on multiple fronts, and things will get better. And the thing that offers me the most hope is that hopefully this won't be a problem, or as much of a problem, moving forward.
I like that. And I have to ask one clarifying question. Otherwise, I'm going to have to do some more advocacy. But I know SAMHSA is working directly with the FDA on the deprescribing guidelines. Are they advocating for slow patient-led tapers and leave people alone if they don't want to come off? Is that what they're advocating for?
I would hope so. There are members of the Alliance that are currently on that committee. And that's what we hope that they're advocating for. I don't have any inside knowledge as far as exactly what's being advocated for, but they are in our group. They subscribe to our holistic mindset that this should be a patient-led initiative. So I feel pretty confident that that's what's going to happen.
You scared me. I was like, don't make me find somebody's email address. I will show up. I will drive there and talk to them. I am not scared because I'm like, come sit with me for a day. You can hear all the stories of misguided deprescribing. I have, unfortunately 10 a day sometimes. It's horrific. All right. So yeah, go ahead.
And you know what, even though like my main frame of reference is the Alliance here, and I also teach for a college, and a lot of my students know that this is subject matter that I am very interested in. I've had students already come to me and give their own experiences with benzodiazepines. And like you said, oftentimes it's a cold turkey or a very quick taper. I've had students come to me and say, oh my goodness, what can I do differently here? And a lot of times these are younger people too. And that's sad that there's been that exposure in our youth.
Well, and that, this is a later conversation with another board member, Doran, I think, but about
Yes.
public health, like the impacts of when you taper someone off very quickly, then they get worsening anxiety, then they get put on an antidepressant, and then they can't sleep. And because it's the failure of the medical system to notice, wait, this is the withdrawal syndrome. It's not a relapse. It's not a new condition. It's possible that could happen, but because of that lack of knowledge in the medical field, it's just, I think the public health impacts of deprescribing inappropriately or not slow enough have long reaching things on people's lives. It really isn't, it's a long-term thing. Yeah. Okay. So thank you everybody for attending. Who is next week? Wait, let me look at my form here. Doreen is next. So we're going to talk about lived experience of benzodiazepine withdrawal with Doreen next week. She's also the public health person that I just mentioned. So we'll talk about that a little bit. So thank you, Jolene. Do you have any closing thoughts, any last thoughts that you'd like to share with our audience?
Just that there's a light at the end of the tunnel, and that we are working very diligently and putting a lot of effort into getting these prescribing, deprescribing practices put into better alignment.
Thank you so much. Thank you for the work you guys do at the Alliance.
Thank you.
I'm just so proud of you. I'm just happy to bring these conversations. It brings hope to my audience because they're like, why isn't this stopping? Somebody help. So everybody out there, I want to say that before we close, just that each one of us, even from our beds, even from being in the middle of withdrawal, you do have the power to help change this even a little bit, even if it's just like file a MedWatch report, talk to your pharmacist about your experience, talk to your doctor when you feel better. Share your story with a friend, write it up, share it anonymously, share it on your Facebook page, something. I think we all have a little bit of power, even though it doesn't feel like it sometimes.
And, we actually have a letter that patients can send to their local legislators, be they, and we can send it to you. Reach out to us at the Alliance. So info@benzoreform.org, or you can send it to me personally at Jolene@benzoreform.org. And I will send you a blank letter that you can send to your representative, your local government officials, that they are aware of this problem, because it's really about getting that power back and feeling like you're in control of the situation, even if it's a little bit.
I love that. And if you send that to me, I will post it in the comments so that everybody has it.
Okay.
We can post it publicly. It's awesome. Okay. Thank you so much, Jolene. Thank you for having me. Thank you for speaking with me today. Thank you for all the work you do. Thank you for advocating for patients. Thank you for training pharmacists, for training students. We need 1,000 of you. Thank you. Thank you. Okay. So everybody else, we'll see you next Friday. I think it's Friday, April 20th. No, so that's Thursday, April 20th at 1 p.m. Eastern. We will be speaking with Doreen from the Alliance for Benzodiazepine Best Practices. You can catch all these. They're recorded. They're kept on my Facebook page. The Alliance is going to start releasing little clips on their social media pages, and it's available on YouTube later, a couple days later, because we have to do a little quick editing. But thank you for attending. Please share this. Please share it with your family so they understand what you're going through. And just thank you for attending today. All right. Everybody have a good one.
Bye.